I am Dr. Carey. I'm a pediatrician in Ventura, California, and we are talking baby care. Today I'd like to introduce Dr. Vaidya. Dr. Vaidya is an otolaryngologist, or in terms most of us can understand, ear, nose, and throat physician with West Coast Ear, Nose, and Throat. He is here to discuss babies who have tongue tie. Welcome.
So, tongue tie. Well, it's great to be here. Thank you. Tongue tie simply is a tether of the tongue. So, during development, before birth, the tongue is naturally tethered to the bottom of the mouth. And during development, that slowly releases. There's a little tether that holds our tongue to the muscle, and in some people that tether is either tight or short or attached too far forward. And so that is a tongue tie, effectively.
And then when a child has tongue tie, how do you determine? I know there are many classification systems. One of the classification systems we used to talk about was simply whether a child can stick their tongue past their lip or not, but it's become a little more complicated than that.
It has been, to some degree. So there are now multiple classifications that look at both function and look at the anatomy itself. The classification systems look at how far the tongue can protrude. They also look at how wide the tongue goes, how far the tip itself can move left or right to the roof of the mouth. They also look at the actual tongue tie, where its attachment is, how much of the free portion of the tongue there is, versus, so the location of the tether, and then they measure that. Some classifications measure that, plus the actual length of the tether itself.
For babies who are having difficulty feeding, are there certain types of tongue tie that tend to lead to more of a problem, or can any of them lead to feeding issues?
In general, unless it's, I would say there's fairly good agreement that the severity of the tongue tie, and however you want to define severity in terms of the anatomy, has some correlation to speech, in the sense that if the tongue is tethered to the bottom of the mouth, there's going to be a speech problem.
You do that well.
But there are many grades in between where people can accommodate for speech pretty well.
Mm-hmm.
The other side of it is the nursing. So when babies wish to nurse, the severity of the anatomic classification doesn't at all seem to correlate with the improvement that the baby will get after a procedure to release the tongue tie.
Mm-hmm.
Kids that have tongue tie have a difficult time latching. That's really the biggest issue. So if kids have a difficult time latching, it inherently creates pain for the mom. There's breakdown of the skin barrier, and that often leads to the thrush because of the milk that's in the area, the sugar, and so just the breakdown of the skin can lead to the thrush.
When do we start to think that maybe tongue tie is the issue?
So that's also somewhat a little bit all over the board. The trend, I will tell you, is it's going more and more towards earlier and earlier, for the simple fact that the procedure is a very low risk procedure. And so it's one of those situations where the mom looks at it, they're having trouble, like you said, they're very frustrated. Is there something that you can do? And so they come and say, well, can you do something? Now, the reality is somewhere in between. We don't know if releasing it that early is necessary, helpful. Certainly by a week or 10 days, if the mom's having trouble, or if the baby's having trouble, it's reasonable. But I do get more and more referrals for kids that are newborns that 24 hours, 48 hours. And if it's a significant tether anatomically, then I will often go ahead and release those. If it's not a significant tether, I'll often say, well, why don't you come back in a week, 10 days, let's see how much better you're doing. And that's part of the classification system issue as well. If it's a significant tether and we think it may impact issues other than nursing later in life, then I think it's reasonable to release it. There's a good chance they're going to need it anyway.
Now, oh, go ahead.
And then just to finish the thought, if it's anatomically not a significant issue, and the purely only reason that we're doing it is to release it for helping nursing, and I don't see much of a tongue tie, what's now called a posterior tongue tie, I might tell them, why don't you try a week?
And for those in which tongue tie hasn't been addressed, to what extent can it become a speech issue down the road?
So speech itself, the tongue is a remarkable organ. It can compensate quite a bit, and the rest of your mouth can compensate pretty well. So I've seen people that have what many would consider a significant, or a moderate, let's say, moderate to significant tongue tie, and they've compensated for their speech very well. So I think it's unpredictable. It's not that everybody with a severe anatomic tether will have a severe speech problem, but there's a much higher chance, I think, because they have a harder time compensating.
Are there multiple procedures that are done, or is it basically one procedure?
So there are two broad categories of procedures.
Okay, and we're going to have to make it brief because
Okay.
we only have a moment.
Sure. So one is effectively you snip it. The second one is you snip it and then you put stitches in.
Okay.
Pretty much for all babies, I do it in the office, either no anesthesia or a little bit of local anesthesia. We snip it and then they do well.
And your complication rate has been?
Essentially, I have had no complications.
I thank Dr. Vaidya for joining me in discussing this perplexing problem. I am Dr. Carey, and I thank you for watching. For more baby care education and to sign up for our free newsletter, please visit us at drcareys.com. And remember, at Dr. Carey's, we teach baby care.
Breathe in, breathe out. Breathe in, breathe out. Okay, let me see your ears.